Okay, well, thank you for joining us here on this beautiful evening. As Will mentioned, my name is Merai, and I'm an internist, but more proudly, I'm a geriatrician. We are kind of zebras in this world, so I've trained in geriatrics, and I really have a passion for cognitive health, and so that's what I'm hoping to share a little bit with you today. I think this talk is about 10 to 15 minutes, so we'll open it up for questions at the end, and then feel free to kind of pull me to the side if there's any other questions you might have. Brain health is a number one concern for a lot of my patients. When they come to me, it starts off with something like, I forgot, where I put my keys, or, I walk into a room, I need something, I can't remember what it is, I go out and then I come back and I remember it, or forgetting names. And so oftentimes this is what prompts patients to come to me and say, or the primary care doctor and say, okay, do I have dementia? And so today I was hoping to kind of lay out, what is dementia? What are some signs to look out for dementia? Where we are with dementia? What are some of the updates that we have in dementia care? And then, end with things that you can do to prevent dementia. So dementia, if we start off with terminology, dementia is actually a term that we really no longer use. The technical term that we now use it's called Major Neurocognitive Disorder. Part of this was the stigma that's attached to dementia. So for any Latin buffs out there, it comes from the word demens, which basically means out of mind or loss of mind. And so we've moved away from that terminology. Now I will resort to probably saying dementia, so forgive me, but again, the term we use now is Major Neurocognitive Disorder. And so some of the signs to look out for. So I'll kind of lay out 7 signs that, again, may be normal, but may also prompt you to start that discussion with your primary care doctor. So the first one is, a decline in memory, of thinking, or of attention. So you may find that tasks that were pretty easy for you are now maybe taking longer, you're getting distracted easily. Changes in mood or behavior. So this oftentimes comes from a spouse or a partner that says, my partner is a bit more withdrawn, is acting differently. Not necessarily complaining of memory complaints, but is maybe feeling a little bit more down or depressed. Decline in functional abilities, so not being able to do the things that they were able to do before, balance a checkbook, drive from point A to point B. An increase in confusion, repetition, so they're kind of going back to those same stories again and again, or asking, what time was that appointment? And then 10 minutes later, what time was that appointment? Changes in language, right? Saying, okay, that's a pencil, but I'm just gonna call it thingamajigga, not being able to recall the names of objects. And then decline in social cognition. This last one is interesting. So social cognition is this whole new term. It's this ability to know that if I look at you, I can read your facial expression, I kind of know what you're thinking, I could have empathy. And this is a whole new domain of cognition that we're recognizing that if people are not able to do that, there may be a type of dementia. It may not be Alzheimer's, it may be another type of dementia, but that is now a cause of concern if there is a change in that social cognition. And so that's new since 2013. And so what is dementia? It's this umbrella term that says that there's a problem in one or more of these domains that affects your everyday function. That is the most important part of this. So it affects your everyday functioning. So you don't remember an acquaintance's name. You don't, you forget something when you go into a room, but then you can go back and you remember it. Is that necessarily affecting your function? That's going to be the first question that we need to ask. But it's those issues with those domains that cause problems with your function. We need to start having that conversation. What's going on? Now, dementia is an umbrella term. Alzheimer's is the most common type of dementia, but there are other kinds. There's things like vascular dementia, Lewy body dementia. There's also frontotemporal dementia, and then there's also mixed dementia. So patients might actually have two separate kinds of dementias. But dementia is kind of that umbrella term. So right now, just to lay it out there, about 5.8 million Americans in the US have dementia. And they're estimating that by 2050, there'll be about 15 million with dementia. But what's important about dementia, and especially as a geriatrician, it's not necessarily just the burden on the patient, it's the burden on the caregiver. And so currently 16 million Americans are caring for loved ones with Alzheimer's or other types of dementia. Just to put that out there, that's 18 billion hours of unpaid caregiving. And that comes out to $280 billion of unpaid caregiving. Oftentimes falls on partners, adult children, quite frankly, depending on culture, daughters. And these people, the caregivers, may be in the sandwich generation. They're taking care of their children, they're taking care of older adults. And that can take a toll on their health. And so as a geriatrician, I often, will check in with the caregivers because they oftentimes have more mental health issues and often more just other health issues because they're not taking care of their health. Their health is not being prioritized. They're taking care of their loved one with dementia. So kind of moving on, what causes dementia? I'm going to focus specifically on Alzheimer's dementia. And basically what it is, to kind of keep it simple, is that it is the buildup of protein in your brain where it shouldn't be. This protein is toxic to your brain cells. And I'm going to put the names of two proteins out there because you're going to hear it in the news. One is called tau protein, and the more important one is called amyloid protein. And as I'll talk about therapeutics later on, the goal is if we can take those proteins out, then maybe we can prevent dementia from happening or from progressing once you do have it. And so the only way to detect this before was autopsy. So I would never say, oh, you have Alzheimer's dementia. I would say you have probable Alzheimer's dementia. And then on autopsy, post-mortem, we would say, okay, we see these proteins built up in the brain. But now times have changed, and so we have different types of imaging out there. So we have PET scans, we have MRIs, and then we can even tap the spinal fluid and look for amyloid protein in the spinal fluid. And I'll talk about the pros and cons of those things, but we don't necessarily need to wait to post-mortem to have a definitive diagnosis. So, okay, so now you're saying, maybe I have one of those signs, it's affecting my function, what do I do? So you go to your primary care physician, and they're gonna start with getting your basic history. When did this start? How long has it been going on for? How quickly is it developing? And hopefully, if it's a good primary care physician, they're getting collateral information. So they may be asking a spouse or an adult child, what are you noticing? Because obviously sometimes what we report, either we could be in denial about our symptoms or we don't necessarily have a true, accurate view of what's going on. And the spouse may be the one that said, yeah, they were supposed to go up to Skokie for an appointment and they ended up at the Wisconsin border. That type of information is really helpful for us. So first we start off with the history. Then we'll do a physical exam, obviously checking you out, doing the neurological exam. And then we do some cognitive testing, some basic, pencil and paper tests that we can do in the office. These might be things like the MOCA exam or the mini mental or the mini cog test. It's a screening test, so it's kind of giving us a little bit more information. And then, there are these new tests, computerized tests that have been FDA approved. There's several of them that are being used for cognitive screening. Tests like Cognica, and there's some other ones that are out there. And so this may prompt us to say, okay, this is abnormal. Let's do some neuropsychological testing. So I might send you to a neuropsychologist who does 2 to 3 hours of testing, looking at different parts of your domain, different domains of your cognition. That gives us clue. Is this Alzheimer's? Is this fitting more of an Alzheimer's pattern, or maybe this is more of a frontotemporal pattern? And then based on that, we might order some brain imaging. So we might start off with an MRI of your brain or a CT of your brain. There are PET scans that can actually look at amyloid, but this is being done more in the research realm. And then there's also tapping of the spinal fluid to look at the CSF to see is there amyloid there. So that's kind of the general workup that we might do. You might ask, well, what about genetic testing? And there can be a role for genetic testing. Something that we might test for is the ApoE4 gene. Maybe you guys have heard of it, which, before we check it, obviously we want to do counseling. Do you want to know this information? Because based on the treatments that we have, which we'll talk about, they're not that great. great. So do you want to know that you have a neurocognitive disorder that we may not be able to treat the way that we can treat, a lesion in your heart with an angioplasty or a stent? So the first thing is, do you want to know this information? Second of all, just because you have this ApoE4 genetic mutation doesn't mean you're actually going to get Alzheimer's. You may have an increased risk, so if you have one version of that genetic mutation, it increases your risk 5%. If you have two, maybe 15%, but again, it's not a guarantee that you're going to get it. This will slightly change in the future. Some of the therapeutics, people with the ApoE4 genetic mutation respond differently, so that may be one reason to get it if you're being considered for treatment. But right now, it's not a knee-jerk reaction to get genetic testing. It can be done though, and if you do some of this commercial testing where you do the cheek swab, you can send it off, you can learn your ApoE4 genetic status. So it may help with some of the picture. And then brain imaging we talked about, and then analyzing your CSF, the fluid that surrounds your brain and your spine. Now what's really interesting, and I think what is actually most exciting, are some of the blood tests that are coming out. There's a new one that was just approved by the FDA. It's called PrecivityAD. And this is a test that actually looks for amyloid in the blood. And based on that, they check your ApoE4 status and your age. For those people that are having cognitive changes, it can give us, with some probability, whether you have Alzheimer's or not. This test is $1,250 right now. It is not being covered by insurances. I have ordered a few kits for our office, so it'll be interesting to see if anyone is interested. It's going to be a learning experience, I think, for patient and for the providers. I think this is new territory, but this technology is out there. Quest has also come out with something similar for $500. So this is mainly for patients that have some cognitive changes, and we're trying to see, is there amyloid in the blood that might push us towards an Alzheimer's diagnosis. So that's exciting. I think that will come down because it now has FDA approval, and hopefully in the future insurances will cover it. So that gets us to treatment. If you guys have been following the news, you've maybe heard of the medication called aducanumab. It's a monoclonal antibody against amyloid. So it's basically giving you a medication that's attaching to that protein that shouldn't be in your brain, and it's disposing of it. And it's actually the only new dementia drug that we've had in 19 years. So if you look at other, oncology field, the cardiology field, we're getting these new meds, they're being tested. This is the one area where we haven't seen a new med in 19 years. And so obviously there's a lot of excitement about this. There's a lot of hope for people that are maybe in the early stages. But the data is not necessarily kind of, very straightforward. So this drug did get accelerated FDA approval. Basically, the FDA will give approval to drugs that could be helpful, especially in disease states where there's not a lot of treatment. So you want to keep that in mind. And there are complications to this. So it's an infusion that you get once every month. It's for patients in the early stages. So if you have moderate to late stage Alzheimer's, this medication is not for you. It's a monthly infusion, and there can be side effects, major side effects or adverse effects. One is inflammation of the brain. So 4 out of 10 patients will get that, we'll see that on MRI. And then out of those 4 out of 10 patients, 1 out of 10 will have to stop the treatment. And the other one is microhemorrhages, so small spots of bleeding in the brain that then makes us have to stop giving the medication. So because of this, and because of the studies themselves, so there were 2 big studies. One showed that it didn't help. The other one that showed in a subset of patients that it maybe helped a little bit. So maybe when they did cognitive testing, it helped by about 4 months in terms of not progressing the disease. So the benefit is so small, the question is it worth the cost? Biogen said they put the price tag of $56,000 on this medication. Medicare was like, are you crazy? This is insane. We need more data. So even though it's FDA approved, Medicare is saying, no, we're gonna go into phase 4 trials. So if you want this drug, you need to be enrolled in a trial by the government where they're looking to get more data to say, is this actually helpful or not? And so I think this is kind of to be determined. Is this going to be something that it becomes mainstream? is the benefit that is there, is it really worth the adverse effects? I think these are questions that are not answered, and hopefully we'll get more information as we get more data. The other interesting treatment that is starting to be in the news, if you've been keeping a close eye, is something called transcranial pulse stimulation. The data is not great for this. We're really seeing it more in Europe, in particular Germany. It's basically where you put an ultrasound probe to the head and you send these acoustic pulses to different parts of the brain. And the idea is that it helps to build blood vessels in the brain, and it helps to restore some of those connections that are lost with the nerve cells. There's been no double-blind randomized controlled trial, which should be relatively easy to do. So I think this is kind of the beginning stages. So that's something to kind of look out for, especially because the downsides are very few. It's 6 treatments, 30 minutes each over 2 weeks. And they've seen some benefit in patients when they do neuropsych testing. Does that actually translate into real life benefit? I think again that still remains to be seen, but there's almost no adverse effects to this. So this is something hopeful that we'll kind of keep an eye on. And so I just want to end, what are some ways to reduce your risk of getting dementia? I think that's kind of what all of us are trying to do and look at. And so there was this very large study by The Lancet where they did a meta-analysis. They looked at all these, they did a literature review, and it came down to things that I think you won't be surprised. Things like physical activity, right? That moderate activity for at least 150 minutes a week. Things like correcting hearing impairment. They're finding a link between hearing loss and dementia. So correcting hearing impairment if you have it. Level of education, right? Stimulating that brain. They found that patients that have a higher education level have more of a cognitive reserve. And so it's taking those master's classes and doing those things, even in your retirement. Learning a different language. Social interaction, incredibly important. Not only to address isolation, but also, as patients are planning out their retirement, I'll often have that discussion. It always, it tends to first be a financial discussion. Do I have the money for retirement? But it's also, where are you going to go? If you're going to travel, do you have a network of friends there? All of those are important questions to be asking as we're planning retirement. Sleep. There is a strong link to poor sleep and cognitive changes and loss. And then diet. So they've been looked at, several diets have been looked at, and the Mediterranean diet and the Mind diet are 2 diets that have shown that there's some cognitive improvement. These tend to be diets, the Mind diet actually came out of Rush, research from Rush, and these tend to be more vegetable, fresh fruits, nuts, olive oil, so high in omegas, limited on red meat, and then they allow 1 glass of wine. So, that's there. It's not totally depriving you of that.
That's not good.
Per minute?
What's that? Per minute? Not quite, but so these are, and it's basically diets that are also going to be beneficial to you from a cardiovascular standpoint. So those are some things for prevention. And I always get asked, are there supplements out there that can be helpful? And supplements are a multi-billion-dollar industry. And so I'll kind of go through a few that have been thrown out. So one is vitamin B. And taking a vitamin B complex vitamin can be helpful if you're vitamin B deficient, but they found that if you're not vitamin B deficient, B12 deficient for example, it's actually not helpful. So just making sure that you're getting your vitamin B through diet. There's a supplement called L-theanine that showed maybe some improvement in cognitive performance, but it should be mixed with caffeine. And the main source of that is green tea. So drinking a cup of green tea can be beneficial. It has the caffeine and the L-theanine. They also found that in blue zones, so these are areas where there's higher percentage of centenarians, places like Japan, green tea is a big part of their diet. So,
That's called a blue zone?
Mm-hmm, the blue zones, yes. So these are areas in the world where there are more centenarians, so people that have made it past 100. So that's Osaka, Japan, Sardinia, Italy, and in the US, there's a place in California where there tends to be a higher population of Seventh-day Adventists. probably because they're vegetarian, they don't drink. So there's more centenarians there. So they've studied these populations, and they tend to garden more. They tend to drink red wine, especially like in Sardinia. They drink green tea. They do physical activity. They're outside. They're getting sun. So there's a lot of research around, especially in the longevity research area where they've been studying these people. So green tea it has the L-theanine, omega-3. So that's part of the Mediterranean diet. They did another study, is taking omega-3 supplements better than omega-3 in your diet? And there was no benefit as far as cognition for omega-3, so it's really incorporating it in the diet. There was vitamin E talked about, but really it wasn't found to be helpful for patients that are trying to prevent cognitive loss. So again, vitamin E through the diet, that's gonna be your leafy green vegetables, your seeds, your nuts. That's your better source of vitamin E. Ginkgo and ginseng. So ginkgo had a larger trial. It was called the Ginkgo Evaluation Memory Study. It had about 3,000 older adults. Didn't really show that it prevented or slowed down dementia. Ginseng, same thing. Turmeric is interesting. It has antioxidant properties. There was a study out of UCLA that found that people that took turmeric did better on memory tests, had less buildup of those proteins, the abnormal proteins in the brain. But it was a small study. It was about 40 people, and other research really hasn't found this result. So more studies are needed there, but putting those extra spoons of turmeric or eating more Indian food may not hurt you. And then there's something called CDP choline. So there are 14 studies done around that, but again, the evidence is not quite there. And then what's been in the news lately has been trehalose and rapamycin. So they found that in mice, it helped to prevent, or it helped to actually break down some of those proteins, what we call autophagy in the brain. So I think that we still need to kind of see how the mice fare, try it in humans and see how that goes. So, my overall message about supplements is really you need to get this through the diet. And again, the Mediterranean diet and the Mayan diet are two diets to really consider when it comes to preserving your cognition. So that's all I wanted to share today. And I'm happy to kind of open it for questions, or you could pull me aside later on. And
well, I think I got 3 out of 5 of your points now. And that drug that you mentioned, what's the status of that drug in Europe?
So there was so Genentech had filed Biogen had filed to be considered in Europe. They just pulled it, so it's not being considered in the UK.
So
they're one step behind.
It's just an expensive piece of nothing.
Yes.
Okay. You answered my question.
Scientists are fighting about it, but I think we just need more data. And there's enough adverse. It's one thing if it didn't have adverse reactions, but these are enough for us to be concerned. To the point where now.
What about the brain thing? That would be great.
What's that?
The brain stimulation.
So we'll see. There's no good studies. That's why I'm not saying no, forget about it. I'm just saying we don't have the studies.
There's no downside to that.
Yeah, it's literally putting a probe.
So where can you get that?
You can go to Germany. So next time you're in Germany, I actually tried to Google if anyone does it here, but I couldn't find any clinics.
Why don't you?
Well, think about it.
Why not? I'm done.
Yeah. A physician recommended that my mom take Prevagen for memory and all that kind of stuff, and this is a physician recommendation, so she's fixated on taking it.
Yeah.
So I want to know what your experience with it, if any, is, and your recommendation.
So the data is not there for it.
Okay.
I don't recommend it to my patients. I say, save that money, spend that extra money on buying some berries that are high in antioxidants, and put your money there. Because it's like $30 to $60 a bottle.
I don't even know what it costs.
Yeah, it doesn't do anything, and the data is not there. So I'll tell you that as a physician, it's very hard to have a patient with dementia and not be able to offer a slew of treatments. And so sometimes something like Prevagen can give patients hope, but the data is not there for that.
And can I just get a clarification from you? Alzheimer's. So when Alzheimer's first came on the scene years ago, as I remember from when I was practicing in the healthcare field, Alzheimer's was diagnosed in people who were younger. there was early onset Alzheimer's, and then there was Alzheimer's in people who had memory problems and cognition problems when they were young, a little bit younger, I'm gonna say under 80 or something.
Mm-hmm.
And as people aged over 80 into their 90s and they had problems, it was just called all organic brain syndrome.
Mm-hmm.
And it really was, Alzheimer's was not used for that. Are you telling me now, with data and new research, that someone 95 years old can be diagnosed with Alzheimer's at that point in time?
Yes.
Okay.
And in fact, there used to be this umbrella term called dementia of other organic, that's what they would.
Organic brain syndrome was like
Yes.
the catch-all for having memory loss and stuff as you were much older.
And that's been taken out of the DSM criteria
It
now.
is, okay.
Yeah. So yes, you can, those amyloid plaques can develop to a point of having cognitive changes, but that would be Alzheimer's.
Okay.
Now, some people will have plaque deposits, so a lot of the Alzheimer's, it starts accumulating even before you start having any symptoms.
Mm-hmm.
Which is why there's a lot of, interest in, if I can do a blood test and detect it way earlier, those are the patients that we need to give aducanumab to, for example. So there's a lot of interest in finding what is that preclinical state where you're having amyloid deposits, but you don't quite have the symptoms yet. And so there's a term we use, mild cognitive impairment. But yeah, you can develop Alzheimer's later on.
But you shouldn't be diagnosed with Alzheimer's unless you've had some clinical testing done, other than just filling out, you need to have the plaques in some kind of diagnostic test to get to the diagnosis of Alzheimer's.
Yeah.
Is that what you're saying?
Yeah, basically we put together multiple puzzles of, pieces of the puzzle. So the other thing I forgot to mention was that on MRI, if I just do a regular MRI, we look at places where the brain is atrophied, meaning it's kind of shrinking, it's degenerating.
Okay.
There's patterns to that.
Okay.
And now there's even companies out there that are using artificial intelligence to map that out, and they can say, oh, well, this pattern's more similar to Alzheimer's, this one's more Parkinson's.
Okay.
But we use that picture plus all the history you've told me, and we've ruled out everything else. We've ruled out depression, we've treated your depression, we've treated your thyroid, we've treated your B12 deficiency.
Okay.
It's still a clinical diagnosis because a lot of the other stuff like PET scans are not in regular practice.
So that answers a big question for me personally and my family. Okay, thank you.
But 5 to 10 years from now, it may be, okay, you need to get the Precivity's blood test,
Mhm.
then we will diagnose it.
Okay,
But right now, we're not there yet.
thank you.
Hopefully I haven't painted a grim picture here. Take care of your health now, that's really the message.
Anthony, I just was contacted by University of Chicago for a study they're doing on using Lipitor it's a test to see if Lipitor helps with dementia. Of course, I don't think I've got dementia, but anyway, I've signed up for it. Half of us are going to get Lipitor, the other half are going to get the sugar pill. And once a year, we're going to get a memory test to see what's happening. And only my primary physician's going to get any information out of this.
Actually, they're not telling me anything.
Yeah, they usually can't tell
Yeah,
that.
they told me to not even check your cholesterol.
Well,
If I did, then I'd know whether you were on statin or not.
well, they told me they would let you do that, but you're not supposed to tell me. But anyway,
I'm against doing a test and not telling a patient the results. What's the point?
So there's a type of dementia called vascular dementia. So basically, just as you have plaque deposits in your heart, you start having deposits in your brain, and it can cause a cognitive impairment. And so the idea is that if you bring down your risk factors for cardiovascular disease, theoretically you will decrease your risk for vascular dementia. So it'll be interesting to see what that study shows.
5 years.
5 years.
In the category of treatment, not cure, but treatment, if you have somebody with advanced dementia of any kind, are there ways to give them palliative care so that they don't have as much volatile behavior, mood behavior, make their life more comfortable if you can't reverse it? What's being done there?
Yeah. So yes, there are. What makes dementia very difficult, especially for those 16 million caregivers, is dealing with some of the the changes that happen later on. So agitation is a big one. Patients hitting their caregivers, not recognizing their caregivers. And so, yes, dealing with that, there are medications out there. Now, they're not great. There's antipsychotics that we use, but these have black box warnings for increase in all-cause mortality. There are certain antidepressants that we can use that help with, agitation. And then they're doing some studies on other medications to see, one is an anti-malarial pill, to say, could this actually be helping with some of the behavioral issues with dementia? It's really tough. I think that's where having a specialist is helpful, whether it's a neurologist or a geriatrician, a geriatric psychiatrist. These are people that can help you through some of those grueling stages at the end.
Thank you.
Good job. Thank you.
Yeah, very good.
Thank
Thank
you.